So our total budget for the year is 9.9 million. And 10.1 million for expenditures. For our allocated budget, 823,000 in revenue for the month. And our actuals are coming in at 474,000 in revenue. And our allocated expenditures for the month is 844,000. And our actuals are coming in at 606,000. Next page, please. So government accounting is a little bit different in the fact that when you receive money early on in corporate accounting, you would book that to unearned revenue. And as you earn that revenue, then you would book it into revenue. Government accounting is a little bit different in the fact that if you have that money, you have to book that into revenue when you receive that money. So we received Foundational Public Health Services money last year in 2022, about half of what we were expecting, 2.5. So we received 1.2 in Foundational Public Health Services revenue last year. And at the end of 2022, that was booked into revenue. So right now, if you would look at our Foundational Public Health Services revenue, that is $0. It's important that the financials reflect our general ledger. So I'll get into the adjusted amount here in a second. So our total revenue for the month before adjustment is 473,000. Our payroll expense being at 403,000. And it's going to be compared to our budget, we take the entire year and we divide it by 12 for the monthly amount for the monthly budget. So the first quarter is always a bit volatile as our budget and our actuals come into line a little bit further into the year. And that has a lot to do with activity. This time of year, we're not necessarily as busy in certain departments like environmental health. There's just not as much going on. But as we move into the spring, summer months, that activity will certainly pick up. Any questions about the first page of the income statement? Moving into the next page, down here at the bottom, we're reflecting the FPHS carryover from 2022. So our current year loss for the year is 132,000. If we incorporate all of our FPH funding for the programs that we had for the month of January, that was 193,000, bringing what would be our excess revenue to 61,000. So this is on page 12. Is there any questions regarding that? It's just silly government accounting. I put it towards.
Well, and if I may, since Foundational Public Health Services was a new funding stream, we tried very hard to ask the state to do it differently, but they didn't. So
yes,
we end up with split money, if you will.
Which makes my job a little bit more difficult in that aspect. Or if they would just do the normal corporate accounting and book it to unearned revenue, but we're not. That's not how government is done. Moving into the next page for the programs, we have, and as you can see here, I've grouped them kind of programs by color. But if you look to the left on the program number, that is what we call the BARS accounting. BARS is an internal state reporting system. It stands for Budget Accounting and Reporting System. I had to write that down. It was explained to me very early on that it's called BARS because it was made up in a bar. So that seems to be the case in some of these accounting practices.
It's more sense that way. Thank you.
Yes. Any questions about the first page? And again, it looks a little bit different than month to month because it's only reporting 1 month versus a month and year to date actually. Moving into the next page. Right now, the losses that we're showing in EH have to do with the solid waste. We are still currently working through our DOE funding update. We are actually getting more money from them. We're still waiting on that contract to be signed. Once we get that contract signed, we'll be able to invoice for some of that lost revenue, so to speak. Any questions about the program summary? Next page, please. Is our COVID expenses for the month. Right now, we spent just over $43,000 in COVID expenses, mainly being payroll internal expenses.
Monies, there's no monies that the health district has to return to COVID.
No, yeah. Right now, we're on a reimbursement and we have dedicated funding through 2024. Moving into the cash flow, I apologize. This is the year-end cash flow. I did not get I think I sent the wrong spreadsheet for January 2023. So I'll have 2 months to review next month. But the the overall cash balance did not change much. It was, I believe, $11.5 million at the end of January. I apologize for that.
On your cash flows, do we have a reserve?
So the reserve is not necessarily speaking for the cash flow. It's more of an internal idea on how much we would need to operate. Kind of down at the bottom, the number of days for operating cash available compared to the budget. So that will change with our new 2023 budget, and that'll increase quite a bit. That wraps up my report unless there was any.
Commissioner McKinney has a question.
Oh, I'm sorry.
Well, good morning, Chase. I received an email, and I don't know if you did also, but could you just, and I believe I couldn't hear very well, and perhaps Commissioner Curtis's question was this, but could you briefly just give an example of how specifically for COVID, especially that when there are dollars that are allocated, it might look like it's increasing our budget, but those funds have to be specifically for COVID. And they can't be applied to other items. And we have this question come up a lot for other items. So if you could just kind of explain how when dollars are earmarked, they really truly have to be spent on just that particular focus.
Yeah, so we have a contract with Department of Health. We call it the Consolidated Contract. And a lot of that, it funds a lot of different programs. And for those programs, it is specifically, as you said, earmarked for that specific program. We have a couple dedicated staff for COVID mainly, and they're continuing daily work. There is still outbreaks happening in Yakima. Things are getting better, but we are still assisting long-term facilities and schools and any questions that may come in. But yes, we are tracking that specifically for COVID, and we have specific grants for COVID that is charged back to. Does that answer your question, Commissioner McKinney?
It sure does. And thank you. I just thought it would be helpful to just reiterate that.
All right, thank you. That wraps up my report for January. Thank you.
Thank you, Mr. Porter. And Dr. Bark, if you're ready, we'll come back on for you to wrap up your part. Can you hear us, Dr. Bark? There you go. Okay, thank you.
Yeah, I can. It's no problem. All right. So you want me to just talk off my slides, or can you share?
They're working on getting.
Got it.
Okay, you're there.
Okay, so we're done with long COVID, and we'll move on to rebound. That would be next slide. All right, so there's people have heard about rebound. I mean, Tony Fauci and our president both had rebound. So let's talk a little bit about what that means. There's a recent study that was published, which is referenced on the next lines, looking at rebound symptoms for patients that have received Paxlovid for no treatment with Paxlovid. So initially, it was thought that treatment with Paxlovid led to rebound. So a simple study was created to use a daily symptom tracker, and patients were asked to fill out what symptoms they were having. And for those that were treated with Paxlovid, they were compared to patients that didn't receive Paxlovid that also had COVID. For the patients who did not take Paxlovid, 30% experienced symptoms such as cough, fatigue, headache after initially feeling better, which would fit with the definition of rebound COVID. Next slide, please. Because of the possibility that Paxlovid led to rebound, there's been a reluctance to prescribe the Paxlovid by physicians. This, unfortunately, has led to reduction of treatment of COVID with Paxlovid, and in high-risk patients, they can't lower the risk of hospitalization and severe illness without the administration of the Paxlovid. So in this study, both treated and untreated patients, if rebound occurred, the symptoms were much less. So nobody really got severe disease or had to go in the hospital. For both groups, about a quarter of the patients had rebound symptoms. For both groups, there was about a 12% detectable virus during the rebound period. And fortunately, no deaths resulted in either group from rebound. You can see similar rebound symptoms after influenza or respiratory syncytial virus infection. Next slide. All right, so that's the end of rebound, and I hope everybody sees that rebound occurs whether you're treated with Paxlovid or not. So we're going to try and get some information out to our local physicians that Paxlovid is still an excellent way to deal with treating COVID and preventing severe disease in patients that are at high risk. All right, that's by the way from Glacier Basin, if you're a big hiker. All right, next slide. All right, so just a few comments about what's happened looking back with the outbreak and the different kinds of studies that have been published and what they mean in retrospect. So this is under the ethics of clinical research, management of persistent uncertainty. So really all along, we've been uncertain about what the best way to deal with patients who had COVID as far as isolation, uses of masks, medication treatment, how to deal with severe disease in the hospital. And eventually in medicine, all these issues can be fine-tuned by doing appropriate studies. In the beginning of the epidemic, there were really no apparent treatments for severe COVID. So there was a real rush to try and find something that might work. And one of the ways that this is done in COVID and also in other diseases is to repurpose existing drugs based on the mechanism of action. So some of the drugs that were used early on included hydroxychloroquine, lisinopril, and losartan, which are hypertension medications, ivermectin, which is anti-parasitic agents. And many of the studies that were done initially were in small numbers with no control groups and quite varied patient types. So the actual value of those studies was quite small. So the clinical design of the trials is important for determining the value of the data. So generally speaking, we use a null hypothesis method, which is the study is designed to set up the contradiction of the hypothesis. So that means like ivermectin is really good. So they set up a study and they compare patients who have had ivermectin and COVID to patients who have not had ivermectin and COVID. And the design here is to have a controlled study, and the patients are distributed to the two groups randomly. So that's where the randomized control study theory has emerged. And in that way, there's no prejudice about who is developing symptoms versus the therapy. So both the patients and the doctors don't know who's getting the therapy and who's not getting the therapy. Other things to consider are choosing the right thing to study. So for instance, after all the publications that have come out that show a particular agent doesn't work, continuing to use that agent doesn't make any sense. And what is the social value of the proposed study? So for instance, if a therapy like Paxlovid ends up working, there's great social value because many patients are going to benefit from its prescription. Next slide, please. So this is one such study that was done. The title of it is Effective Higher Dose Ivermectin for 6 days versus Placebo upon the time to sustain recovery in outpatients with COVID-19. So there's a very specific question asked with a very specific intervention. And they looked at the data after it was done. It was a double-blinded study. And the doses that were used were a little higher than some of the earlier studies, 600 microgram per kilogram versus placebo for 6 days. There were 602 patients in the treatment group, and the placebo group 604 patients, so a pretty large size. The results is that patients who didn't get treated with ivermectin did just as well as the patients that were treated with ivermectin. So some of the data shows that for the ivermectin treated patients, about 6% were hospitalized, died, or had urgent emergency care. And the patients who didn't receive ivermectin had the same outcome. In the ivermectin group, 1 patient died and 4 were hospitalized. In the non-treatment group, 2 patients were hospitalized and there were no deaths. So very comparable data. The conclusion is ivermectin doesn't help in treatment of COVID in the patient population that was studied. Okay, next slide. So just to end it and show that we still don't know everything, this is a recently published article that the title is SARS Spike mRNA Vaccine Sequences Continued to Circulate in Blood for About 28 Days After COVID-19 Vaccination. And the theory was that the mRNA, which is the main component of this vaccine, would degrade very quickly based on the science at the time. So for some reason, some patients continue to have mRNA vaccine sequences circulating around. There's no data yet to know if that has any adverse effect, but since the adverse effect of the vaccine numbers that are being collected are very low, it's probably not the case. So how do we manage this uncertainty? We just need more studies. And with that, I'll close and be happy to answer any questions.
Any questions for Dr. Bard? Thank you very much, Doctor. We appreciate that.
Okay.
You're going to, Emergency Response Coordinator, Nathan Jones.
All righty, good morning. Few high-level updates, again, recognizing that our IMT deactivated from the Caton landfill response early last week. So at this time, there is no IMT activations currently for YHD. Even though we are deactivated, we're still actively working with the landfill and the Department of Ecology and Clean Air Authority to make sure we're monitoring and staying connected, recognizing that the fire is still smoldering and we're still monitoring and taking data and monitoring that situation. Around MPOX, we just recently completed our internal hot wash and after action review for our internal response to that. With that, anytime we do a drill or a response, we want to look at the CDC has 15 core capabilities for public health emergency preparedness and response. This includes emergency operations coordination, public information and warning, fatality management, medical countermeasures, those kind of things. So for our MPOX response, we specifically looked at our emergency operations, our public information and warning, our medical countermeasures, administration and dispensing, and our epidemiology, surveillance, and case investigation. So we're working on finalizing that report and will be certainly available to the board once that gets finalized. In terms of the COVID after action, it's something we're continuing to work on. We've just recently totally finished our internal staff survey and got all the responses back on that and closed that project. And then we're finalizing over this next week what the external partner survey will look like. And that will go out to the board first, and then it will go out to hospital leadership, federally qualified medical center leadership, community-based organizations, emergency management, State Department of Health, all these different partners that played a role in our response through COVID. And then, so that survey will go out. And then once we get all of that, we'll take the time to go over that data and create a finalized report again, right around June of this year. Other than that, I've been working on a transition plan with Ryan for my position. My last day will be this Friday. So want to make sure that day-to-day operations are able to continue. And then certainly whoever takes this position in the future has some of the knowledge that I've acquired over these last few years for that program and allow them to be successful in that. With that, yeah, so born and raised on the West Side, so recently got the opportunity to for an emergency management position, serving the cities of University Place, Lakewood, and the town of Steilacoom. So that Pierce County area, which is where I'm from. So very excited for that. But really, it's been a pleasure working with this organization and serving this community. And yeah, really excited for the next chapter. So ending there. Thanks, everyone.
So, Nathan, I'd like to say that I first met you via Zoom
Yes.
when I came on the city council in Yakima, and myself and Vicki Baker and Verlin Best approached Office of Emergency Management to have a business task force part of that, to not only help protect the community, but also to give our businesses as early an opportunity as possible to open. So that was our connection, and our relationship over time revolved around that. But I just want to say it's been a pleasure to work with you, and thank you for all the excellent work you've done.
Thank you. It's been a pleasure working with you as well. And all of the board for that matter. Past and previous.
Any other words for Nathan?
Thank you for your service here and we wish you the best as you head back home.
Thank you.
That's certainly true.
I'll just say that from somebody who wasn't part of our management team or in the leadership role, he definitely took that on and he held our group together and he led this management team through COVID and just did an outstanding job. So, thank you.
You'll be missed.
Yes.
One of the interesting things about the incident command system, which is used nationally during emergencies, is that someone becomes the incident commander. And so throughout COVID, Nathan was the incident commander for the COVID response. So I worked for Nathan and he was a good boss.
All right. We're going to move ahead to disease control. Melissa Sixbury.
Hey, I actually have a pretty short report. Actually, there's not a whole lot going on in communicable disease right now, which is great. We're seeing low activity in our flu season, but flu season is not over. So if you haven't gotten your flu shot, we would still encourage you to do so. We are currently managing 4 active TB cases. So I believe one was new since the last time we met, which led to a large contact investigation. So we had 26 individuals that we worked in coordination with Indian Health Services because there was some crossover into some of those patients. We went out and tested 26 individuals for TB. So we're currently waiting on those results and then we'll follow through with any latent TB treatment, or if somebody has active disease, we'll work on getting them treated as well. And Commissioner McKinney, you had asked for some harm reduction numbers and I presented those last month and I know you weren't here, but I just wanted, because we've continued to do unique identifiers for our harm reduction program. So I just wanted to give some more updated numbers on those. Since we were keeping track as of mid-December, we've had 322 visits and 213 unique clients. So we know at this point in the last 8 weeks or so, we've served 213 individuals. And that's the end of my report, unless there's questions.
Do you have any questions?
Just really quick on the TB number of having 4 in a county of our size, is that normal for us or is this abnormal?
We usually have between 5 and 10 cases a year. So to have 4 actively managing is pretty typical.
Okay, thank you.
Commissioner McKinney, you have a question?
Thank you, Chair Byers. I just wanted to thank Melissa for following up with that and continuing to track that. And then Melissa, just a quick question. Were we also, I think I'd asked if we were also tracking for referrals that were made to the individual folks?
Yes, we're tracking those. I did report on those last month. The comprehensive reports those to me at the end of the month. So I'll have more numbers next week. But as of last month, in about a 6-week time frame, we had 11 referrals that were admitted for treatment with comprehensive.
Perfect. I'm really happy to continue to get those numbers and I hope you feel better.
That's actual admissions. There were multiple more interactions or engaging people, but those were individuals who actually got admitted into methadone program or Suboxone through comprehensive.
And I just want to point out that number is striking because I believe it was 11 was the number of referrals over for the 5 years that we weren't tracking. So that's encouraging.
Yes.
Thank you. Questions? We will move into environmental health with Sean McGee. Mr. McGee.
Good morning again. So environmental health, we've been pretty busy with the break in bad weather and a little bit warmer temperatures. Our land development industry is kind of taken off. So we're seeing an early start to our busy season, but we're prepared. We've been responding well, and we're keeping up with the fieldwork demand currently. We're also working we're pretty heavily with our FDA retail food program standards. We've entered into a couple grants that fund some training and allows us to work in partnership with another county, Boulder County, Colorado, similar in size and number of food establishments, on best practices to implement with the resources we have to be as in line as possible with the FDA retail food program standards, which could potentially lead us to future funding opportunities. So exciting work being done in our food safety program. We also are very busy right now as we have 2 of our not county, but 2 landfills in our county that are coming up for permit renewal. The Caton Limited Purpose Landfill needs to renew their permit the end of April, and DTG Limited Purpose Landfill has a permit renewal due the end of June. So we're working with those facilities and the Department of Ecology very closely on getting the necessary documents and designs for the landfills in place, and working just to get them in a spot where they're able to potentially renew their permit. So a lot of work going into that right now, quite a bit of staff time involvement and lots of meetings with our state partners and our 2 facilities to get them what they need to submit the renewal application. So that's most of the work that's happening in environmental health right now. Happy to answer any questions you might have.
Sean, just really quick on the renewals for Caton and DTG. First question is public comment a component of the renewal process? And then 2 is like, how long is that permit active for if it's renewed?
Right, thank you. Yeah, our permits expire annually every year, so they renew every year. The only time a public comment, I mean, anybody can submit comments to us anytime, complaints or concerns. We field those often, so. But a comment on a renewal application is when there is a modification to the facility design, footprint, volume of waste. Where that would trigger a SEPA review. So that goes to all the agencies involved that have jurisdiction on that area. And then there's also a period for public comment during that process as well. So that's the only time it would trigger a public commenting period, is if their modification was enough to trigger a SEPA review.
Okay, thank you.
Sean, there's been a lot of activity in regards to the 2 private landfills in the county. I'm wondering, is there any sampling done or any kind of monitoring done for the municipal waste sites or the municipal landfills in the area?
Yeah, there has been, I know there's some gas collection systems on the Terrace Heights landfill, and there's some more work being done on that. But as far as air quality sampling, I'm not aware of anything that's being done. But again, we don't have the obvious visual signs of any gas emissions coming from the landfill that are any toxic level. We do get during heavy wind events, we get the wind blown debris and some odor complaints, but the 2 county landfills have staff specifically that go pick debris off of private land first and then clean up the landfill site. So, but outside of the normal groundwater monitoring networks and any potential gas collection systems at the 2 landfills, there's no ongoing air quality monitoring being done.
I guess it would just be important that we're not holding a standard to the private entities, that we're not holding to the government entity.
Right, and the trigger for the air quality monitoring for the privately owned landfills is because there's a known source that's causing excess gas emissions in a visual capacity and obviously the smell for it too. So, and we've done sampling events that have shown that there is a potential issue causing those events. So that's the reason for the ongoing monitoring of 2 private landfills. If there was a similar situation in a county landfill, we would be requiring the same thing.
Commissioner McKinney, you have your hand raised.
Thank you. I just wanted to reiterate what Sean just spoke, that there are high measures and bars for controls in place at county landfills, and we are required as a county to adhere to the same type of reviews and methods for monitoring it, and anything that a private industry would also be held accountable to.
Thank you. Any other questions? Go ahead.
Yeah, I just wanted to clarify, in the land of acronyms, Sean talked about SEPA, and that's the State Environmental Policy Act. So it's just a part of a process you have to go through a review. It's pretty extensive, and it deals with a lot of different issues. So it could be the cost, could be traffic control, noise abatement, and so you're covering all these different issues.
Just one last question. So on the renewals, if it's approved by, does this board make the final say, or is it staff that makes the final say on a successful renewal?
Successful renewal is approved by the Yakima Health District with the support of the Department of Ecology. So Department of Ecology employs the landfill design engineers, the hydrogeologists that review those necessary documents when their groundwater monitoring network, the landfill design and fill plan meets the standards that ecology holds them to, and they approve those documents. We get the referral from ecology to approve the renewal
But
application.
we're not going to see that hit our agenda at an upcoming meeting.
No.
Okay.
No, that's part of state mandated responsibilities for public health jurisdictions.
Thank you.
Yeah,
Can-
just real quick. Yeah, so under the WACs, that would be under the authority of the health officer.
And we will move to William Bravo for Arts. Jocelyn gonna cover that?
No, I can give an update if you don't mind. We had talked and Lillian had mentioned in previous meetings that we've taken on the responsibility really for all of Eastern Washington with the breast cervical health program, ECHP. That was done because the Spokane Regional Health District opted not to continue that work, and the State Department of Health asked us to take on that responsibility. It was additional work at a difficult time, but we've been able to build really quality relationships with groups like the Fred Hutch Cancer Center and others. It's been a really wonderful process for us because I think the staff reflects on the fact that the work that we've done over the last decade to improve efficiency is working quite well and working with these other new subcontractors, if you will. Having said that, it's a temporary fix. I think it's important that there are more than one, what we call prime hub in Eastern Washington. And so I'll be working with the State Department of Health on that and actually meeting with Dr. Umair Shah, who's the Secretary of Health for the State Department of Health on that issue. It was a just-in-time request. I take it as a personal vote of confidence that we're seen as a strong advocate for women in Eastern Washington, but nonetheless, it was a heavy lift, not done by me, but by our staff. And we want to avoid those kinds of just-in-time requests because it's a lot to ask of people midstream. But having said that, it's gone quite well. I do want to recognize that it's not just Lillian and her team working on this, but it's our finance team. It is an intricate process to pay for these programs. Again, it's not just cancer screening, it's payment for services, which means subcontract relationships with clinics. It's for people who are underinsured or uninsured. It's critical, but it's a complicated process, and it requires us to keep track of contracts, meet and exceed standards for contracts, pass audits, and it's a pass-through program with lots of money. So the more money, the more critiques, if you will, in terms of how that money is spent. So have I done justice there? Okay, good. So that's our process. Again, it's been a good working relationship, and it's actually allowed us to work with counties that we don't normally work with on a day-to-day basis. So it's more than just a cordial relationship now, which allows us to build partnerships long-term. So I think I'll leave it at that. Any questions if you have them? Thank you.
Seeing no questions, and we're going to move on to new business, and that's going to be introduced by Mr. Arnold.
Okay, so prior to March of 2020, our board meetings were scheduled for an hour and a half from 8:30 to 10 o'clock. And then when COVID came along, there's a lot of information to share, and so meetings got pushed to 3 hours. And then as even more information came about and a lot more discussion, we had started having 2 meetings that were scheduled for 3 hours apiece. When COVID activity decreased, we went back to just a 1 meeting, and this board decided to go ahead and let's leave it at 3 hours at this point. The last several meetings have been 2 hours or less, and so that's why this agenda item's on there is, do we want to go ahead and schedule that time now for 2 hour meetings? I don't know. one and a half hours like we used to do might be pushing it. We've got the spotlight that we have added in, so that does take up some time. So then the recommendation would be scheduling 2 hours meetings for out of respect for everyone's time.
We're open for comments. Well, for one, I will say, I'm going to go next, but for one, I will say that I really like the spotlights, and so I like the additional time allotted for that. It's been very helpful to me as a board member to get that information, so.
Just the last 4 months, I mean, you gave us a rough idea. How long have the board meetings lasted? Last 4 months?
Yeah, so we've had about 2 of them that pushed up to the 2 hours, maybe about an hour and 50 minutes, and then we've had a couple that have been between the 1.5 and 2 hour mark.
I'd agree with that. Spotlights, they're great. They're very helpful.
I'm not opposed to moving to 2 hours. I just throw this out there. Have we always, as a board, met monthly pre-COVID? Is that kind of the typical, or were we a quarterly based meeting?
Yes, it was a monthly meeting. The only time we don't meet in a month is around the holidays. So we combine the November and December meeting to the first Wednesday of December. And like I said, they were an hour and a half long. And once in a while we run up to an hour and a half, but most of the time we finish, like I said, the last several meetings, it's been under 2 hours.
And going to the full 2 hours gives us that little bit extra time if there's a long discussion about something. Okay. Commissioner McKinney, thank you.
Thank you. Just a quick question. I know it's for scheduling and I'm supportive of Ryan's recommendation. I'm just wondering, just for point of order, I would imagine that if we're nearing, the 2 hour mark, I don't know, would we necessarily have to just cut off if we were, for example, if we were having a conversation, an update, and it was clear that we were going to be ending soon, I'm certain there would be a little bit of leeway to be able to go to 2 hours and 5 minutes or 2 hours and 10 minutes. Can you maybe speak to that, Ryan?
Yeah, so in the past, there were times when we went over that hour and a half time, and it was just the chair would just mention that we're running up to that time, and is everyone okay with extending the meeting? And usually it wasn't an issue.
I know city council is the same, we don't really schedule an exact time, but we expect it to be around an hour and a half. And we just go on for as much time as necessary. We can always note when we're coming close to the 2 hour mark. I think it's just a matter of helping us to plan as a board.
I guess I'm sure buyers, I would just say that, yeah, if there's no, hard stop at the end of the 2 hours and we can proceed if there is a need, and I see no need or no reason to oppose this. A motion to approve. I'll second that.
So we have a motion by Dr. Atterbury to approve the move to 2 hours and a second by Commissioner Lindy. All those in favor, please say aye.
Aye.
Any opposed? All right, thank you. It passes. That brings us to the point of adjournment. Unless anybody else have new business? Anybody else have new business? And then it brings us to the point of adjournment. Oh, raise your hand. Thank you, Commissioner McKinney.
Oh, I just wanted to say, I know that Victoria had mentioned to Chairwoman Byers and Andre that I was going to be running late, but I just want to let everyone know that I apologize for not being there in person, but I had a phenomenal experience seeing some of our rural healthcare being administered today to some eye patients. So it was wholly related to this meeting, but I do apologize and appreciate everyone for their participation today and look forward to watching the part that I missed later.
Thank you, Commissioner McKinney. I believe we're adjourned. Thank you, everyone. Thanks. It was very good. I would like to add something. So that is it.